Allergy to anaphylaxis. After learning, students should be able to understand the pathophysiology of the reactions, explain causes and effects of the events, select an appropriate laboratory investigations to help diagnosis and monitoring of medical treatments, and the most important thing is to manage and select the best blood components for patients to prevent the reaction that may occur again. Transfusion reactions can be classified into two main groups, acute and delayed, depending on the onset of the reaction. Both groups are also divided into immune and non-immune mediated based on causes. Immune-mediated reaction means that patients produce autoantibodies specific to red blood cells, white blood cells, platelets, or plasma, while the non-immune-mediated reactions are caused by other factors. Allergy to anaphylaxis is classified as immune-mediated acute transfusion reaction due to antibody to plasma proteins. Signs and symptoms of allergy to anaphylaxis are vary from mild to severe, including urticaria, which may itch, erythema, sharply circumscribed breast lesion, usually on upper trunk, hypotension, but typically no fever, flushing, angioedema, respiratory distress including hoarseness, stridor, wheezing, and chest pain, GI tract disturbance such as nausea, vomit, or diarrhea. Pathophysiology of allergic transfusion reaction is not clearly understood. A combination of patient and donor factor is likely involved, since patient with atopic predisposition seems to have higher rate of allergic reaction, and platelets of some donors are associated with an increased risk. However, the main point is patients produce IgE-type antibodies specific to donor plasma proteins. When again exposed to allergen, antigen-antibody complex bound to IgE receptor on mast cells and induce degeneration. Vasoactive amines and other mediators including histamines release, resulting in allergic signs and symptoms. Two types of anaphylaxis are explained. They are called anaphylactic reaction and anaphylactoid. Those reactions are based on the same pathophysiology but different in source of antigen. In anaphylactic reaction and anaphylactoid, antibody produced to plasma protein is not IgE, but it is IgG or other type that can activate the complement pathway. Anaphylactic reaction and anaphylactoid present more severe signs and symptoms compared to allergy due to the action of C3a and C5a. Firstly, C3a or C5a generated during complement activation bind to its receptor on mast cells, leading to degranulation and releasing of mediators, resulting in allergic presentation. Secondly, C3a and C5a also can bind to its receptor on smooth muscle cells, which leads to contraction, resulting in clinical signs and symptoms of GI tract, respiratory tract, and cardiovascular system. Anaphylactic reaction is suspected if antigen is proved to be IgA or haptoglobin, but no other plasma protein antigens are defined in case of anaphylactoid. This picture demonstrates the mediators released from activated mast cells and its effects on various cell types. Urticaria is the only transfusion reaction in which transfusion may be resumed after prompt treatment. When allergic reaction is suspected, transfusion should be stopped and antihistamine should be started. If patient responds to antihistamine, it confirms allergy. The transfusion may be resumed and no laboratory investigation is required. If severe urticaria presents or patient did not respond to antihistamine, anaphylactic or anaphylactoid may be focused. Antagonists to H1 and H2 receptor and steroids should be started. Epinephrine of 0.5 mg intramuscular or 0.01 mg per kilogram for children dose is recommended for first-line treatment of anaphylaxis, and the dose may be repeated up to every 5 minutes. If shock and respiratory distress develops, including bronchospasm and laryngeal edema, the transfusion should not be resumed because it can be life-threatening. Anaphylactic shock may occur in IgA or haptoglobin negative patients who develop anti-IgA or anti-haptoglobin. So, investigation for anti-IgA or anti-haptoglobin together with the absence of those antigens in patient's serum should be performed to differentiate anaphylactic reaction from anaphylactoid. There are two approaches to prevent allergy. First, pre-medication with antihistamine 30 minutes before transfusion. Second, use of watched cellular blood components in case of need. To prevent anaphylactic reaction, IgA or haptoglobin negative blood component is suggested for patients who has anti-IgA or anti-haptoglobin. Avoid implicated donor, and in case of need, plasma-free or watched cellular blood components are recommended for both anaphylactic reaction and anaphylactoid. Whether there are some typical and common presentations between allergy, anaphylactic, and anaphylactoid, but there are still some different signs and symptoms that can be used to differentiate those reactions. This table compares allergy, anaphylactic reaction, and anaphylactoid in context of signs and symptoms, laboratory investigation, pathophysiology, incidence, and prevention.